Good morning, ladies and gentlemen. I want to congratulate the Dental XP family for being so innovative and having such a fantastic symposium this year. Yesterday was amazing, and I really enjoyed being part of it, and I can see everybody feels being part of a family. So this morning I'm going to talk about bone augmentation and some of the different concepts that I would like to review, because this is something that we cover all the time. Before I start, I'd like to make a disclosure that I do have some direct financial gain about some of the products that I'll be discussing, because these are some of my patents and have some commercial agreements with piezo surgery for the bone fixation system and the bone harvester system, and also some of the instrumentation of Vista through A-Titan. So I just want to be very clear about this disclosure first. So when we talk about bone augmentation, we're talking about different aspects. First, we're talking about the technique that we're using. And when I ask people, well, how are you doing with your bone augmentation? They say, well, this technique works or it doesn't work. It's not whether or not the technique works. You have to ask what material are being used and what is the protocol that is being applied. So to say, let's say, a GBR works or doesn't work doesn't mean anything unless you examine all the steps, all the material that are being applied in that sense. So what we like to talk about in terms of any form of tissue regeneration, you have to have convergence of several modules that have to come together in order for this bone augmentation to succeed. So first you have to have progenitor cells. You're not going to create anything in the body without the progenitor cells, the mesenchymal stem cells in the oral cavity. They have to have a scaffold to nest within, and these are all very primitive cells. The progenitor cells, they need some signal to guide them to the phenotype that we desire out of them, whether it's bone or mucosa. We need the right signals to guide them to that phenotype. And then if you're creating new tissues, you cannot create it in a mobile environment. You have to create stability. Whether you're creating bone or soft tissue, stability is real important. You have to have blood supply. And because we're working in the oral environment and it's the dirtiest part of the human body, we have to protect our regeneration site from the oral environment by keeping them covered. So when you have these 6 elements that come together, these modules, only then we can be successful in our regenerative efforts. If one of them is deficient, the whole thing could fail. So what I like to apply that to is the concept of modular bone augmentation. And modular bone augmentation is just reminding us that as we approach our patients, there are different modules that we need to draw upon, because some of these modules are provided by a site. Some of these modules are provided by the environment that we're trying to work out of. Others, we as the surgeon have to put them deliberately into that environment. So we have to start every patient care with risk assessment. What are the elements of the risk for the patient? And the first aspect has to do with the definition of the morphology of the defect that we deal with. Do we have a flat morphology? Do we have concavities? If we're dealing with vertical augmentation, do we have walls? What is the thickness of the wall? And that's really critical. So the classifications that we've had up to now have not adequately defined the morphology of the defect as a risk factor. But this particular classification, which is the ABC classification, I think is the best that I've seen in terms of achieving augmentation and correlating it and validating this particular classification. And this classification is based on the availability of walls. So you can see that class A is one that has 2 walls. Okay, it's a 2-wall defect. Class B has 1 wall, and class C is flat. So you can imagine that if you have the 2 walls, it's a much more suitable environment for regeneration, and that's a saddle shape of a defect rather than completely flat defect. The other aspect has to do with the width of the defect at the crest. If it's wide, more than 6 millimeters, that would be class 1, 2 being medium, and then class 3 being very narrow. So you can imagine that A1 is the best defect, and C3 would be the worst defect. But we need to have validation of that. The validation came in this particular publication that went through the case series and outlined the outcome of these cases based on a particular technique. This is a cortical tenting technique that was performed for this bone augmentation. And when the defects were classified according to ABC classification, you can see as you go from left being the A2, go all the way to the right, which is a C2, you can see that the percentage of success, which is in blue, goes down. And also the failure was only present in C2. These are flat defects with narrow crests that needed to have vertical augmentation. You can see those implants are the only ones that had actual failure because the defect was not conducive to augmentation. So the first thing is to understand that the defect morphology is directly related to our ability to predict outcome. And if we know that right in the beginning, we know for ourselves as clinicians what to expect, and we can also set up realistic expectations for the patient. The other aspect has to do whether our regenerative effort is confined within or intraosseous, such as an extraction socket or sinus, or are we dealing with extraosseous defects where we need to do ridge augmentation horizontally or vertically or in 3D. So when we're dealing with intraosseous defect, this particular publication by Mariano San's group, which created these intraosseous defects, these dehiscence defects, clearly demonstrated that when we're using biomaterial, in this case BioOss, and a collagen membrane, this was adequate to build good volume of bone intraosseously within these defects. So we don't need to have additional elements. Yesterday you heard some of the studies that Danny Boozer had performed and published, demonstrating that autogenous bone is necessary when we're venturing outside of the alveolar housing. So it's important to recognize that. So then, how we venture outside the alveolar housing, there are many different approaches, and as we see from many clinicians, each of them have merit, each of them can lead to good outcomes. It's just as we select our technique that we feel comfortable with, we have to have certain criteria in terms of predictability, complication rate, patient morbidity, ease of application, and then we'll be able to select the technique that works best for us. And for me personally, the use of particulate graft using tenting technique or the tent-pole technique works very well. And this is a paper by one of our faculty at USC, Bak Lee, who described this very well, and others such as Massimo Simeone have described this technique very, very well, using the tenting screws as an element to create that stability that we discussed that is necessary and the scaffolding to build the bone. So what I like about this technique is that it gives us flexibility. Just like with building a tent, depending on what size and shape and form of tent is desired, we can use different tent poles and create many different kinds of tents. And the same thing is that we can create different topographies of bone based on our design of the tent poles that we're using. So just as a way of demonstration, a patient who had vertical deficiency in an area, so we start this process by looking at the classification of this defect, and we see that it was basically a B classification where there was one wall. By extracting that lateral incisor, we make access to the bone of the central incisor, so we're increasing our wall length. So we are classifying this as an A classification because now we create two walls by extracting a tooth to give us additional wall in this area. Next thing is that we install several screws, a lot of screws, because we're trying to build in the buccal direction, we're trying to build on the occlusal direction, and many people forget about building on palatal or lingual because that's where the implants will go. Most people just start to build buccally, and then when they go to place the implant, they have dehiscence on the lingual or the palatal because of lack of bone there. So you have to envision the shape that you want to create and put these tent poles according to those locations. Using the particulate, a combination of autogenous and xenograft, we're able to build a great deal of volume, and then we're able to reconstruct the patient in this case. So this technique is something that has personally worked very well in my hands, and whatever technique works in your hands, that is okay, and there are many different approaches. But what I found as a surgeon, the obstacle have been the screws. The screws have not always been best designed for the type of application that we're using. These are no different than what we find in a hardware store, in Home Depot. They're no different. They all have the same kind of Phillips head that is used, and many of us get very frustrated, especially our residents who are starting with their first surgery. They keep dropping the screw down the patient's throat because these are not very, very stable. So what I thought about in terms of the changing some of these concepts was to come up with a screw that was more stable, and that's one that has a hex, that has an external hex, so the driver fits directly on top of it. So this is a modular screw or mod fix because there's no head. We're separating the fixation function from the other part of it, which is for the tenting aspect. So for fixation, we need to have a very stable head, and that's in the form of a hex, and the driver fits directly over it. So for the fixation, you have two types of threads. You have the macro threads and the micro, which is right at the crest. So within that 1 millimeter of the micro threads, you have many, many threads to give it stability when it reaches the crest. And then the different degrees of tenting. So depending on how much augmentation is needed, you have various lengths of the neck to allow the tenting up to 10 millimeters. So then we separate the function from what is needed, what technique is being utilized. So on the left is for membrane fixation. So the head that is used, or the abutment that's used for membrane fixation, is a very simple abutment just to fixate the membrane. If we desire tenting, we need a wider surface area. And this also has the eyelets, so you can actually suture the flap or other material to that. And then there's also, for block fixation, there's a tapered abutment for that purpose. So we're separating these functions, so on a modular basis, one can select one or the two. And then the two anodization, the colors signify different diameters, 1.2 or 1.5 millimeter diameter. So if we're trying to achieve bone regeneration, we're using a GBR approach. We need the particulate. The first is to understand that we need autogenous bone. And harvesting the autogenous bone using a rotary harvester, as I will demonstrate to you, makes it very convenient to have ready-made particulate. Once this is harvested, we mix it with a form-stable biomaterial, a very slow turnover to keep the volume. For me, what works well is a xenograph, and there's plenty of documentation in the literature for this mixture of xenograft with autogenous bone. The problem is that we don't always have in same clinical trials the use of these different biomaterials, so we can select, but there's plenty of documentation of using these two combination of a xenograft on autogenous bone as a form-stable, volume-maintaining biomaterial, but also as osteoinductive using the autogenous component. Next is to kind of envision what is the shape that we want to build. We look at this ridge and say we need how much horizontal, how much vertical, in which areas on the facial, on the palatal, and the crest. So this is the shape that we envision. So if this is the tent that you want to build, where would be the tent poles? So you have to imagine what would be the tent poles to support this particular tent. So then those are installed at the proper angulation, so the head of these tent poles have to support this tent. So then this particulate mixture is added to build that contour to support, and then a barrier membrane is placed. For me, a resorbable, not stiff membrane is what we need. I don't need the stiffness from the membrane. I derive it from the tent fixation screws, because every time we use non-resorbable membranes or we use highly cross-linked membranes that are very stiff, there's a biological price to be paid, which is the increased morbidity, increased complication rate, increased exposure of the membrane. So I prefer a non-cross-link resorbable membrane. Then the abutments are connected, and what is nice about this is that we are actually using these screws both for membrane fixation as well as tenting, so they're performing two functions. So this is some of the studies that we did in a rabbit jaw using this particular fixation system to demonstrate that if we're just using a xenograft, you can see from the outcome is that the screw actually osseointegrates beautifully. You can see this beautiful osseointegration of the threads in the bone, and you say, well, do you really need that screw to osseointegrate? Yes, but because you want it to be stable, but removal is not a problem. Usually the removal torque is somewhere around 10 newtons. You can easily torque these out because they're so narrow out of the bone, but they achieve stability, and it shows that the material is very compatible. But when we're looking at what is achieved in terms of bone augmentation, you can see that not much. If you're just using a xenograft, you cannot build outside. The bone is not formed in what we call de novo bone formation. You don't form it in the center. You form it from the parent bone just by apposition, and you can only gain 1 or 2 millimeters of bone as outside of the alveolus. So if you're trying to achieve vertical augmentation, horizontal augmentation, it's not sufficient to just use an osteoconductive material. You need that osteoinductive element, and Danny Boozer had done several studies, and this is one of them, to demonstrate that when you add autogenous bone to this, you increase the ability to form native bone in here. And so the addition of the collagen membrane as well as the autogenous bone in this particular study demonstrated clearly that there's better bone formation. So you need the membrane and you need the autogenous bone. There are different ways to get autogenous bone. You can certainly use a block and grind it up, create particulate. You can use a a filter to capture what is being ground down as a slurry, or you can use a bone scraper, or you can use one of these rotary bone harvesters. Are they all the same? No. Clearly, there was a study done by Rick Myron, who showed that when you use piezosurgery for harvesting, that bone is not vital. When you use a slurry, that bone is not vital. So what worked best in this particular study was either using the block and particulating it, morselizing it, or using a scraper, because these are harvesting vital bone. So the same token is that the method that we use for bone harvesting is critical. So what I will show you is this particular bone harvester, which actually only penetrates about 3.5 millimeters and can harvest very quickly, within seconds, autogenous bone that is perfectly particulated and ready for application. And that's something that allows us to have sufficient amount of autogenous bone. Because when my residents are using bone scraper, they're scraping, and they say, is this enough? No, scrape some more. Again, they keep going until they're exhausted, ready to fall, and say, okay, now we have enough. We should have at a minimum 25% to 50% of autogenous bone, and it's very hard to get that with a bone scraper. So this is a very convenient way to harvest it. So let's put to task these concepts and treat this patient. This is a lovely lady, a school teacher, who has had bad luck having implants here and some failures of implants by multiple attempts by one of the local oral surgeons. So she is really embarrassed by this appearance because of the high smile line, and you can see she has a significant vertical defect here. So if we look at this, you can see that the adjacent teeth that has lost periodontal attachment, those are the problem, because the more periodontal attachment is lost on the adjacent teeth, that limits the amount of walls that we have. So if we think about defect morphology, those walls are rather short. So one method that we can use to lengthen these walls is to use orthodontics. In the last case, I demonstrated that we extracted a tooth to come up to a tooth adjacent to that has longer bony wall, or another option is to use orthodontic. And in this case, we use orthodontic extrusion to lengthen the walls on both sides so that we can convert this to an A classification vertical defect. So orthodontic extrusion was used, and what we did was to move the canine into the lateral incisor position in order to make it a single tooth defect rather than a central lateral, which we know that Maurice has always talked about as a very, very complex defect to reconstruct. So you see that what we've done by orthodontic extrusion is to lengthen these walls and turn this to an A classification, which is more conducive to regeneration. Harvesting the autogenous bone, either from the anterior nasal spine or the retromolar area, mixing it in equal volume with the xenograft, and reconstituting with the LPRF. And you can see that some of the LPRF membranes, we actually mince those and mix it into this, because that brings a lot of inductive elements to our regenerative sites. The LPRF is actually very conducive to having neovascularization and also recruitment of some of the cells that are desirable for the regeneration. So then we start installing these tenting screws in the contour that is desired. The particulate graft is added once the membrane is stabilized to the palatal. The particulate has to support the site that is being regenerated, and these abutments that are connected are fixating the membrane as well as creating this tenting effect that's needed. Now, do we want to add bone to those denuded root surfaces? No. You cannot achieve periodontal regeneration by just adding bone on top of the roots. So for the denuded roots that we have on the facial, we're going to add connective tissue graft that you see up above. There's connective tissue graft placed on the denuded roots, and then we layer it with LPRF to improve our tissue response. So you can see this is the site after closure. So we can see that we've been able to achieve large amount of volume for the patient. Now, this is still a work in progress. This patient is almost ready for final restoration now, but we've achieved a lot of volume using this technique. And you can see the canine that had significant amount of periodontal attachment loss has been moved into a lateral incisor position, so we have a single tooth defect that would be much easier to restore at the end. So I want to demonstrate another case in the posterior mandible, which is an often site that we need to reconstruct. This patient had a relatively recent, about a year and a half before this, bone augmentation in the area of a premolar. And what is notable here is when you look at the CBCT of the patient, there's a defect in the middle of the symphysis because the oral surgeon in this case used a trephine to harvest some bone and placed it into a defect. And you can see the bone is still highly immature in this area of the premolar because this is a significant defect that I don't know what other biomaterial was used in here, but it wasn't successful in regeneration. So we're going to try to do our regenerate effort. One of the things that we will use is the very careful flap management technique. Now, when the mucosa is thin in these cases, many colleagues attempt to use a free gingival graft or a connective tissue graft to thicken the biotype. I like to tell you, in my view, that's not a good approach because what that does, it scars the tissues and makes it more difficult to get mobilization. Now I see that I'm installing this tenting screw. The first screw that I installed is called Unifix. It's basically a one-piece screw, and the additional screws that are being installed are the two-piece or ModFix modular screws. So you see that we are building them horizontally and installing a number of these screws. And then the anterior screw is the shortest one just for membrane fixation. We're also using the same site, harvesting autogenous bone using this rotary harvester. The way I view this is that if we're harvesting the bone from the same area, we're also decorticating. The area actually allows to have vascularity, so instead of having individual pinpoints, we can actually have larger area of harvesting to have a decortication effect. We're mixing that with the LPRF and the xenograft in this case to have a bioactive and form stable, low turnover type of a graft material that will be used kind of like a stable graft. So this is the mixture that we have, which is a mixture of autogenous xenograft using the tenting screws, barrier membrane in this way. Now, one of the things that I see some of the speakers are using very frequently is bone tacks. To me, what I see is that this is actually something that can actually significantly make cases worse. The problem with the bone tacks is that when people use a bone tack, if not used properly, it can actually completely obliterate the space. Why? Because if a sufficient flap is not reflected, if you only have a partial flap that doesn't go high enough, what will end up happening is that the bone tack will compress the membrane in the area that we hope to achieve augmentation. So if you're adding this graft material and using these bone tacks, but the bone tacks are placed in the middle of where you want to achieve augmentation, you're not going to be able to achieve regeneration. You actually compress the membrane against the host bone and obliterate the space, and you end up with a shape that is partially augmented. So to me, bone tacks usually make the results worse if not used properly. The next thing is mobilizing the flap, and in the posterior mandible, it's really critical to have on the buccal side a periosteal incision. Now I see many different techniques of periosteal incision. Many people make a very deep incision. Many people make multiple incisions. All of those things will actually make it worse because you're disrupting the blood supply. The key to this is that you make one very superficial incision and then you stretch the flap. You see, as you stretch the flap, this is a blunt dissection that allows you to have a lengthened flap without really disrupting the blood supply. And what is critical in the posterior mandible is also the lingual dissection, which comes from separating the mylohyoid muscle from the flap. Now in this case, we're placing the abutments, attaching it to the membrane, and you see that the abutments, because they have a eyelet, we're able to actually suture the abutment to the flap. So you can actually pass the suture to the head of those screws to fixate the flap to a fixed structure. That way, you're not fixating the two margins of the flap that can open up because of tension. And then you have to fill the space underneath the flap with underneath the membrane with lots of this regenerative mixture of biomaterial to support the membrane, something that Esteban Urban refers to as a sausage technique, basically filling this casing with the particulate graft. So you can just basically stuff underneath sufficient amounts of this mixture to support the volume. So this is the result. You can see both horizontal as well as vertical augmentation. We have lots of bone volume for these implants that are being placed. So I mentioned to you that I prefer not to do the soft tissue augmentation before, because as you're trying to mobilize the flap, you make that periosteal releasing. If there has been another augmentation prior to that, the soft tissue augmentation, free gingival graft, that causes scarring of the periosteum, makes the flap less mobile. So actually will counteract against us. Soft tissue augmentation is very important, but I prefer to do it at the time of implant placement in the form of a connective tissue graft. Then you can look at the pre and post-op and see that initially you see that after all this time that harvesting of the autogenous bone from the chin, which is using a trephine, which is a very deep harvest, is still there, versus what we achieve is that because the harvesting using the rotary harvester is so superficial, it's completely gone. So we also have used the VISTA technique, the vestibular incision, subperiosteal tunnel access, along with this bone augmentation. So this is a very good case for that, where we trying to augment the area and we want to use a tunneling approach from the vestibular side. Is this my idea? No. I like to give credit to people who have used this type of a vestibular tunneling well before I started publishing or discussing about VISTA. Fuad Khoury and Michael Block were the first ones to describe this particular approach for vestibular tunneling for bone augmentation. Now there are many people who are taking credit for it, putting their own name after it, and this is really, I think, turned into almost like a circus because everybody wants to have their name on the technique, you know, as if they invented it. There's nothing new in dentistry. And what we need to do is we need to give credit to people who thought about these ideas rather than claiming that we are so genius to think about all these ideas. So many who should be credited for their approach. So vestibular incision, subperiosteal tunnel is optimal here because it gives us full access to our regenerative sites. We're trying to basically gain access by separating the mucoperiosteal flap from the bone. And you can see that in this case, I'm trying to create this tunnel. And now we have different elevators. These Vista elevators are improved in the way that they achieve this vestibular tunneling because they have a square head, and they have this square head that actually goes right up against the bone very efficiently, creating this vestibular tunnel. And you can see that we're also going posteriorly to be able to achieve root coverage for these teeth. And also we're using the same vestibular access for harvesting the bone from the apical areas, from the symphysis areas, using this rotary bone harvester. You can see harvesting the bone from the same site, mixing it in, and installing the screws. You just have to push the Vista access and install these screws into the area. It gives us pretty good access to the whole regenerative area. Now, the only thing is that when you're using vestibular incision for this purpose, you just have to make a longer incision to give us better access. Then adding the membrane particulate graft and the tenting abutments to be able to fixate the area. And looking at the result, you can see that we created a large volume using this because we did not make the crestal incision because the tissue is so thin. Especially we tried to do the extraction and the regeneration at the same time. Typically, I would do the extraction, just like what Danny was describing, waiting 6 to 8 weeks for the mucosa to fully heal before we make a crestal incision. In this case, because we didn't make the incision, we didn't want to add to it another crestal incision in a very thin mucosa patient, so Vista worked very well for reconstruction. Now, when we place our implants is when we want to do our soft tissue augmentation. You add a connective tissue graft, in this case, preferably from the tuberosity, to augment the mucosa to be able to make the tissue more stable and resilient. Now, one thing I want to say to you is that when you do bone augmentation, volume augmentation by GBR, typically we're making the vestibule shallower. So you have to plan on vestibuloplasty. So in the cases that you saw, you do a connective tissue graft in conjunction with implants. In other cases, you do vestibuloplasty. There have been studies using vestibuloplasty with free gingival graft or with mucograft, showing both work very well. I just show you an alternative to that, and that's what I like to show you. A patient who has very shallow vestibule is going to have a complex prosthesis in this area, and you can see that with a very shallow vestibule, it would be a very problem with the hygiene. So the implants were placed using a two-stage approach. During the second phase of uncovery of the implant, we're doing partial thickness dissection of the area, leaving the periosteum on the bone. Now we're installing those mod fix screws into the bone because what we want to do, we want to keep the vestibule down. If you just use sutures, it's very hard to keep the vestibule down. Using these fixation screws makes it easier to keep the vestibular flap apically. And what we're doing, we're filling the space with LPRF. We're actually putting the LPRF on these tenting screws and placing the abutments to stabilize the LPRF to the area. You can see we put at least 3 layers of the LPRF membrane. This is no different than what other people had done with Mariano Sanz and Esteban Urban using the mucograft for the vestibuloplasty. In this case, we're using a more bioactive material, which is the LPRF, to fill in to enhance the healing process. And you see that once these caps are placed, it is now I'm using the sutures to suture to the eyelets of those tenting screws. Now, what I found is that you actually don't even need the suture. For the first case, because it was my first case in this case, I used the sutures to make sure that the LPRF stays attached. But in future cases, I only use the tenting screws without the LPRF, without the sutures. So you can see the before, and we gained a lot of keratinized mucosa deepening the vestibule because we were able to successfully keep the flap in an apical position using this fixation system. So we didn't use any kind of a autogenous palatal graft in this case. So as I mentioned, in these cases nowadays, I would just use the fixation screws, and I put the fixation screws through the flap to keep the flap in an apical position, as well as to stabilize the LPRF without any sutures, and we're gaining lots of keratinized mucosa, deepening the vestibule, increasing the thickness of the mucosa in these cases, which is essential for the long-term survival of these implants. So just to conclude about what we've been discussing, is that the initial step in any process for patient care is risk assessment, classification. That will know for you as a surgeon, clinician, what would be the expected results, whether or not you can expect a large volume of bone, or whether you need to reconstruct some of it using prosthetic reconstruction, or come up with a different treatment plan, or even propose multiple augmentations if you need to completely reconstruct the volume. Next thing is that as you will approach through your the actual case, you need to select the right technique that you like to use, select the biomaterial and the protocol, and this is really the key to having the steps that will be defined. And you don't want to change it every time, otherwise you'll never know what is working and what is not working. The scaffold is critical in this case. You use either a xenograft or allograft, preferably for me is a xenograft, because xenograft is so biocompatible and also it maintains the volume so well. But if you're using that for intraosseous defect, that's all you really need is a xenograft. But if you're trying to venture outside of the alveolus, you cannot do that just by adding a xenograft. You need to add autogenous bone, or in some cases, RHBMP2 or other inductive elements to venture outside of the alveolus. Vestibuloplasty is often necessary in these cases because as you build volume, you're pushing the vestibule back to the palatal in case of maxillary, or toward the lingual for the mandible. You shorten the vestibule. You have to do soft tissue augmentation, but my suggestion is don't do the soft tissue augmentation first, because that will scar the periosteum and will work against you as you're trying to mobilize the flap. It is necessary, but the best time is to try to do it at the same time as the implant placement. That way, we're reducing the number of steps and the number of surgeries that we subject our patients to. With that, I really appreciate all your attention today. I want to congratulate my dear friends, Maurice, Henry, and David, and it's a pleasure to share this information with you.